Good morning.
Good morning.
Good morning. Let me give just a moment for participants to come in, and then we will commence the webinar. Okay, good morning, everybody, and thank you very much for joining this webinar. I'm going to just begin with a fact statistic. 1 in 10 women still do not have access to maternity care in the first months of pregnancy, and 2/3 of newborn deaths are avoidable with appropriate care. And essentially, that's why we're here this morning with this very distinguished panel and to launch a report, a comprehensive approach to maternal health. My name is Barry Andrews. I'm an MEP in Dublin in Ireland. I am a founding member of the Women's Health Interest Group, which is supported by the European Institute of Women's Health. I'm a member of the FEM Committee on Women's Affairs and Gender Equality. And it has been my pleasure to serve on that committee in the last 2 years. While the maternal mortality and infant mortality rates have significantly decreased in recent years, this does not paint the full picture. As I mentioned at the very beginning, there is a challenge for almost 10% of women who do not have access to maternity services. And who are these 1 in 10? Marginalized and vulnerable groups such as migrants, refugees, and Roma women experience worse maternal health outcomes, and these disparities must be tackled with a sense of urgency. Pregnancy is a key moment that requires a specific focus on health and provides opportunities for addressing health vulnerabilities. As high as 98% of drugs have insufficient data on the safety of use in pregnancy and breastfeeding. Sick women get pregnant and pregnant women get sick. This is unacceptable that in 2023, pregnant and lactating women must continue to take medications with no health safety data. It is time that we include women in research and data collection so that they can make informed decisions about their health. Currently, the European Union is expanding its competence in the area of health, and a particular feature of this expansion is the European health data space. And it is critical that maternal health becomes a part of that and that women are participating in data and research. With nearly half of all pregnancies in the EU being unplanned, we need better access to and availability of family planning clinics and services across the EU. Furthermore, pregnancy, contraception, fertility, and sexual health should not be solely a woman's issue. We have to engage more men to ensure that we are all playing our part in promoting maternal and infant health. The Women's Health Interest Group in the European Parliament was launched just a few months ago in October. The objective of this group is to embed women's health in the work of the European Parliament by uniting and to promote the best possible access to prevention, treatment, and healthcare for all women. I want to conclude by saying that a critical window is opening for the promotion of maternal health here in the European Parliament and in the EU institutions. As most of you will know, there are European Parliament elections in June of next year, in the first couple of weeks of June of next year. And between that election and the formation of the new European Commission, which will probably be in the autumn, there is a critical opportunity for campaigning and advocacy to ensure that maternal health is very much on the agenda for the future European Commission and the future European Parliament. It is excellent that we already have a women's health interest group, and making sure that that is present in the next mandate is crucial, but also influencing the Commission's agenda for the 5 years that will follow. So with that, it is my pleasure to hand over to Peggy McGuire and to Rebecca Moore, a senior researcher at the European Institute of Women's Health, who will present the findings of the latest report. Thank you very much.
Thank you very much, Barry Andrews, for your supportive introduction speech, and it frames my next session very well. So I'm presenting to you the report that we commissioned on maternal health in the European Union. So next slide, please. Thank you. So what we wanted to do with this report, part of the reason why we wanted to have it commissioned and have it done, was that we wanted to establish a knowledge base on maternal health with the aim to be able to support any action to improve maternal health and maternal care, and also to realize the right to safe pregnancies for the very diverse body of women within the European Union. And to be able to do this, we needed to be able to trace the trends and disparities in maternal health and their outcomes as well in the EU. So the objective we have is to summarize the available evidence and any statistical data that we were able to find on maternal health and also access to care. And we've mapped this evidence and the prevention strategies to guard against any risks as well. So we've used desk review research, we've used data sources and also published studies and also grey literature to be as comprehensive as possible with all this work. Next slide, please. So maternal health in the European Union, it encompasses the health, according to the WHO, as a good definition of it, maternal health encompasses the health of women during pregnancy, childbirth, and also the postpartum period. And this links directly to broader aspects of health that underpin maternal health, which includes general health and also family planning, sexual and reproductive health. So there's been a paradigm shift in maternal health from preventing maternal deaths to more promoting women and health being in the Western world. And in this paradigm, pregnancy is viewed, this is very important, as a window of opportunity into the current and future health of women. It offers a critical entry point for women who may otherwise not seek or have access to care for chronic conditions. Next slide, please. So the outline of the report looks at trends in social and economic and geographic and health situations. So firstly, we talk about the maternal health care journey. We have public health, we have health promotion, and we have disease prevention. Then there's access to care and information, and then labor and delivery, and also health condition management, and very importantly, safe use of medicines during pregnancy, but also during lactation. And also within the maternal health care context, we have the socioeconomic supports around the time of birth to the various groups of women where the needs are very different. We have disparities and within these vulnerable populations that we'll be talking about. And we need research, and we need data, and we need investment within this area. And we also need policy in Europe, and that's what this is all about. Next slide, please. Here is just a map, and I'll be coming back to this later, the effect of age at birth of the first child in women. And you can just see there's the different trends here, with some Southern European countries being much older than certain Eastern European countries. Next slide, please. So with regards to public health, health promotion and disease prevention, there are well-known risk factors contributing to adverse maternal health outcomes. It's the socio-economic situation of the woman, it's the underlying health conditions, and it's the obesity epidemic that's affecting everyone across Europe. We have early intervention for health promotion and disease that we know is very effective: nutrition, exercise, and smoking and alcohol consumption, and also very importantly, vaccination during pregnancy that can help a safe pregnancy for these women. We have examples of this. The European Health Information Gateway details the rate of influenza coverage for pregnant women across the EU according to country. And also we have the common European standardized dietary methods with dietary reference values, which are required for a healthy pregnancy. Next slide, please. Continuing on with public health and health promotion and disease prevention, there are approaches to health promotion and disease prevention that we found in the report to be very helpful, like screening and influencing behavior change, and also supporting protective behavior and alleviating behavior with harmful effects such as smoking and alcohol consumption. And the European Board and College of Obstetrics and Gynecology, they recommend that there would be a uniformity of diabetes screening, which would lead to a timely diagnosis of treatment in a greater number of women. But at the moment, there is no consensus on the optimal approach. With regards to maternal obesity, it varies within the European Union from 7% up to 25%. And this is strongly related to social and educational inequalities. And unfortunately, most European countries do not systematically report on obesity figures in their pregnant population. And next slide, please. So access to care and information. So we talk about a 5 A's framework in dimensions to access with 5 corresponding abilities. So the dimensions are approachability, acceptability, availability, and accommodation, affordability, and appropriateness. And corresponding to approachability, we have ability to perceive. Acceptability, there's ability to seek. And availability and accommodation, we have ability to reach. And affordability is ability to pay, and appropriateness is the ability to engage. And just to give a few examples of the disparities encountered by various women, a major barrier in accessing maternal care in some of the European countries is the inability to pay for it. This is obviously an issue for women living in poverty, and also within women, vulnerable women that are undocumented, and they have a less secure financial situation. And in many European countries, they are required to pay. And this has resulted in non-Western women with an origin that's non-Western having a 60% higher rate of maternal mortality. And also we have lack of access to pharmaceutical due to cost. So women are not taking the medicines that they might need to because they can't afford it. So it's the interplay of health systems, laws, policies, socioeconomic factors, and attitude of health professionals and the users themselves that all contribute to these issues. Next slide, please. So we looked as well at labor, birth, and delivery, and there's a huge variation in cesarean section rates across Europe. The median being 27% in Europe, and the lowest can be found in Northern Europe. Iceland, Finland, Norway, and the Netherlands, they all came in under 18%, while the highest rates were in Italy, Hungary, Poland, Bulgaria, Romania, and Cyprus, with over 35% of cesarean rates. And this is constantly increasing. Between 2010 and 2015, there was a 4% increase across the EU. And thankfully, maternal deaths in the EU remain lower. Well, for us, I suppose, in the EU, remain lower than in many other high-income countries. But we still have problems with substandard or poor quality of care being associated with up to half of these maternal deaths. And there's evidence of an increased risk of maternal death among older mothers, and that's where the map comes in that I showed you earlier at the average age of pregnancy across Europe. And also complications related to cesarean sections also play a part here. The most prevalent causes of maternal death were embolism, hypertensive disease of pregnancy, and hemorrhage. And there's a rise in risk factors for adverse maternal outcomes during labor and delivery, which include maternal age, obesity, and migrant status. Next slide, please. So another issue that came up in the report and that we've been working on for a long time at the EAWH is the safe use of medication during pregnancy. So Europe lacks a comprehensive regulatory information system that addresses the use of safe medicines during pregnancy. And 90% of pregnant women in high-income countries take medicines during their pregnancy. So this is clearly very problematic. And as Barry Andrews also mentioned, over 90% of medications currently have no information about their potential to cause birth defects. And with 1 in 5 women having difficulties understanding information given about medicines during pregnancy, this is clearly an issue. So we're working on the IMI conception study, which is aiming to collect data on medicine use in pregnancy, and we're setting up a platform providing comprehensive and accessible information on research into medicines and to become a go-to platform in an accessible language, letting women know any teratogenic effects of medicines and also on breastfeeding. So we see this as a priority area to invest in. And because pregnant women and lactating women are to date mostly excluded from clinical trials, we need to disaggregate the data according to sex and gender, and this needs again to be a priority. And if anyone's interested, please contact me and I'll talk to you more about the IMI conception study and what we're trying to achieve there. And next slide, please. So we concluded our report with steps for actions. So we put them into 5 different categories: enact and enforce, support and promote, protect and empower, partner and care, and research and engage. So under enact and enforce, we're looking at support for the clinical trials regulation and for the work and life balance directive and the EU maternity leave directive, and also to enforce gender equity measures. Under support and promote, we would like to see mainstream maternal and infant health in EU programs and strategies, and funding of maternal and infant health research, promote healthy behavioral approaches, and also target infectious disease and prevention and mitigation. And under protect and empower, we'd like to see accessible, affordable services for all pregnant women and children, and to promote multilingual open source information, and support an EU-wide system on safe use in medicines, and also to design and implementation of services and policies around the need of all populations experiencing vulnerability, to have a special focus on them because they're the ones with the worst adverse events. And regarding partner and care, we found that we need to advocate and implement EU maternal care standards. We need to improve health and social professional education, and we also need multi-stakeholder networks on maternal health and well-being, and we need to engage with communities on policy and programming. And we also need multidisciplinary, multisectorial approaches. And research and engage. We need to support cross-national data and research which is sex, gender, and age disaggregated. This is so important. We need to support knowledge and best practice to be shared between member states. And we also need to support the involvement of women and their families, as this is about them. Next slide, please. So for the final slide, we have the high-level recommendations as well that we put together in the report. And so number one being promotion of health and well-being. And pregnancy is viewed as a regular event that takes place at a particular time within a woman's life. And health promotion taken early at critical points from childhood to older age, and to use a life course approach. And also pregnancy is an opportunity to empower women to lead healthy lifestyles. Our second high-level recommendation, person-centered and rights-based approach. And so we're talking about a transformative approach to foreground women's voice and personhood, and mainstream through all available EU policies, and connecting to patient and the public's participation, patient advocacy and partnership as well, and drawing on implementation science and research to exercise these women's rights. And also accelerate the existing instruments for health literacy agenda in Europe is another important point. And with regards to research, we really need more representative and better quality data to be collected. We need to establish a reliable and standardized system for measuring and monitoring this across all EU member states. We also need to explore possibilities of standardization of indicators across the EU, for example, nutrition and diabetes, obesity, all these things that I've talked about so far. We need to prioritize data and analysis to capture inequality among women. And we need to recognize that there's a diverse population of women in Europe in regards to age, socioeconomic status, and migration, and their citizenship situation, ethnicity, which all are affecting maternal health. We also need to integrate sex and gender in research and data disaggregated by sex and gender and age in clinical trials. We need to incorporate all these analysis and have them within decision making in health systems. And we also need to adopt a system thinking approach to maternal health care and research, drawing on the already existing WHO building blocks. And now, that was it for me. Thank you very much for listening.
Thank you very much, Rebecca. Rebecca is a senior researcher here at the European Institute of Women's Health. I'd also like to thank Barry Andrews for hosting the event, and the EAWH looks forward to supporting Barry and the work of the European Parliament Interest Group moving forward. And we're very, very lucky to have with us today our panel of experts, and I'd like to give you some indication of who we have on board. So first of all, we have Isabel Della Matta, and Isabel is currently the Principal Advisor for Health and Crisis Management in the European Commission. Previous to this, she worked as Councillor for Health and Consumers at the Permanent Representative of Spain in the EU, as Deputy Director General for Health Planning at the Spanish Ministry of Health, as advisor to the Vice Minister of Health, and several other posts at the Ministry of Health of Spain and the regional departments in the Basque Country and in Madrid. We're also very, very lucky to have Elena Kasko, the Deputy Director of the UNFPA Representative Office in Brussels. She is an international development professional with over 20 years experience in international affairs, diplomacy, human rights, gender equality, and international development cooperation. And also representing WHO, we have Dr. Neerja Chowdhary, who is Technical Officer in the Department of Mental Health and Substance Use in the WHO headquarters. She's a psychiatrist by training, and she works in the brain health team and is the focal point for maternal health. Her role includes the development of normative tools and guidance to support implementation of the Mental Health Action Plan. For example, resources linked to WHO's Mental Health Gap Programme aimed at building capacity of non-specialist health workers to provide quality mental health care. And last but not least, we have Mervi Jokinen. Mervi qualified first as a registered nurse and then became registered practicing midwife with further studies at BSc in professional practical midwifery. After working 30 years in the NHS, she joined the Royal College of Midwives in 2001, and in her current role, Professor Advisor to the Royal College of Midwives. She's gradually specialised in leading RCM European International Agenda and is President of the European Midwives Association from 2009 to 21. Mervi had a strategic lead in maximising the representation and influence of EMA in the EU and seizing opportunities to promote women's health, general and reproductive health. So I would like to welcome all of you here to our expert panel, and we look forward now to our discussion. Isabel, can I come to you first? And you're very, very welcome this morning. As Rebecca pointed out, there's a shift, a paradigm shift in maternal health agenda, looking at health and wellness. And I'm just like to ask you, what do you think are the factors that affect mental health outcomes? And do you think that EU policy adequately addresses these factors?
Thank you very much, Peggy. I have to apologize because there is some noise around, but I was in a meeting and I have to go out, so I'm not in the best condition, but I'm trying to do my best.
Well, thank you.
Well, you know that maternal health, as all health in general, is affected by different factors. And the most important are the biological factors, the socioeconomic, also the health system, but it's not the most important, and also other policy or political factors around. While the maternal mortality has really decreased in the last decades, to a point that now 1 or 2 deaths can completely change the statistic, meaning 100% more than the year before. So that has made some confusions with some publication of WHO, for example, when we compare with other countries. What is important now is the maternal morbidity. And there are different factors that are affecting and that we are trying to fight, we as European Union, meaning, but also the member state, not only specifically for that period of life, but in general, in this long life approach that we take. For example, smoking. Smoking, still, there are between 11 and 30% of pregnant women that smoke. And this is very, very high. But it may be more astonishing that alcohol, where alcohol should be an absolute zero during the pregnancy and even before, when there is the intention of conceive, there are some countries that have a rate of consumption of 60%. 60% pregnant women drinks alcohol during the pregnancy. That this is not acceptable and should be fight. And this is happening in the European region of WHO, and this is happening in the EU. And I have to say, sorry to say that Ireland is one of the leading countries in smoking, leading badly in smoking and in alcohol. Then obesity or underweight or overweight. We know also that that this have an impact and have been associated with a higher risk of miscarriage. And this is why the health promotion has a fundamental role. And we are trying to address that with the member state, and we have this newly created expert group on public health that is addressing health promotion and specific aspects. We also count with the gender equality strategy of the European Union that is not specific for health, is not specific for maternal health, but try to address different issues that can influence that. So all the policy decision, all the political decisions that have to do with gender aspects as so important as the parental leave and all the decision about access also to health services. We know that the access to healthcare is really very important. And even if, as I said, it's not the main determinant of the outputs of the outcome on maternal health, is really very important. And the barriers such as lack of skilled professionals or up-to-date care and equipment, or the legal decision about who has access to maternal health has been mentioned in the presentation. For example, undocumented women. Do you know that according to the United Nations Convention of the Right of the Child, is the child, but the Article 24 says that all women shall have access during pregnancy, delivery, and postpartum to healthcare services. And do you know that only 4 countries of the European Union are legally complying with that? Others have made provision to offer those services, but in a nice way, if I can say like that, but not in a legal way. That is really important, and we are following that with the member state. So literacy, health literacy, bad outcomes on maternal health now, well, in general, are also related with the age, with the very early age or more age women. Luckily, now there are less and less teenager pregnancies, deliveries, so that is good. But also there are more and more women that are being pregnant elder than what is concealed. For different reasons, and also the recourse to assisted medical reproduction. That means that the pregnancies are delayed, that there are some tries and that not always successful, so also the pregnancy is delayed, and also that they are going to be more medicalized. All of them have an impact on the maternal health. Also, cesarean has been mentioned, and or other instrumental deliveries that are important and have an impact on the outcomes of the pregnancy. That is also very important. Sometimes it's because of the age of the women, sometimes it's because of the health condition of the women, and sometimes it's just due to it's more convenient for more comfortable, not convenient really, but comfortable for everybody to have a planned delivery and recourse to the cesarean without taking into account the consequences that this is going to have. Also, the data have been mentioned, and the Eurostat, that is who is collecting all the data for the European Union, they are making real efforts on having all the data by sex, at least sex and age, if possible. They are working with the member state. We have nearly achieved that all the health statistics that they are collected are disaggregated by sex. But we continue to work with them on that. The EU for Health, that is our funding program, that is the highest in the life of the EU for Health program, the EU Health program, now has a budget of 5.3 billion euros for the 7 years, and includes an emphasis on health promotion and disease prevention, and also on making medicines available and affordable, and also on access to care for vulnerable groups. So we are trying. There are challenges and also opportunities. The clinical trials have been mentioned several times. We have been working since the beginning, since the new legislation on clinical trials, that what is written in the legislation is really put in place and that no group is discriminated in the participation on clinical trials. And we are doing some progress, but still we are not there. We know that we need to invest still more. So we acknowledge the multifactorial factors that are influencing the maternal health outcomes, and we are working on expanding the policies to meet all the evolving needs of our diverse population. And we are in contact collaboration with the member states, with the stakeholders, with the international partners. WHO, of course, is one of them. And that is essential to ensure that our policies remain effective, responsive, and centered on the well-being of the mothers and the children. Thank you very much.
Thank you very much, Isabel. Quite frightening, the statistics on alcohol consumption and also access, but delighted to see that the Commission is really behind promoting good maternal health in Europe. Can I come to you next, Elena? And we're looking at maternal mortality and morbidity that Rebecca outlined in the report. And we know that they're not evenly spread across in Europe or even the world. Particularly with climate change and political instability, and usually in humanitarian crisis and conflict, it impacts women the most. So what can we do to better support mothers in low resource contexts? That's been highlighted in the report.
Thank you very much, Peggy, and let me thank you for inviting for this panel and congratulate as well European Institute of Women Health for your wonderful reports, which is very timely and important. UNFPA, being a sexual and reproductive health and rights UN agency, is having the maternal health very close to our hearts. And of course, as a global organization with offices in over 154 countries, I mean, we have let me bring a little bit of global perspective to that. As Rebecca alluded to in the presentation of the reports, even in the EU, as you rightly said, the maternal mortality and morbidity rate differs from country to country. And indeed, it is very unevenly spread around the globe. So we have Sustainable Development Goals 3.1 aims to reduce maternal mortality to less than 70 maternal deaths per 100,000 live births by 2030. But unfortunately, today in 2023, we can see that we are pretty far globally to this target. While, as reports said, the maternal mortality rate in European Union region amounts at average 13-15 deaths, the world's average is 223 deaths. And we have the most poor and 9 countries in most dire situations like Central African Republic or South Sudan, for example, where maternal mortality reaches 551 maternal deaths per 100,000. So this is, I mean, it's a shocking, absolutely shocking figures. And of course, as you rightly said as well, mega trends like COVID, climate change, migrations are impacting the progress. You was asking me what can we better do globally, and my answer is, of course, kind of looking to all the countries UN is operating in. So my answer is probably more relevant to the global context, but I think there are plenty of elements for EU as well. So I would just limit myself to 3 main actions, and I would say, first of all, the global action needed to educate and train 900,000 midwives by 2030. And I'm so happy that Mervi is with us because, I mean, midwives is a key person and key professional in eradicating maternal mortality. We should be crystal clear here. Human resources for health, including midwives, is an investment. It's not a burden to the health system. And every dollar, and this is what we calculated as well, that every dollar invested in family planning and maternal health in developing countries benefits for families and societies and bring back around $8. So it's quite a good investment. Secondly, we still have early and unintended pregnancy high worldwide. And this is as well critical to combat this to end preventable maternal death. At the moment, around 57% of women today are unable to take the decision about their body and about their reproductive health and about their reproductive rights. And nearly half of all the pregnancies worldwide are unintended. It's about 250 million women who want to avoid pregnancy cannot or do not, for some reason, use effective methods of contraceptive, for example. And of course, here we see the comprehensive sexuality education for especially young people as a critical key element. And finally, I would like to focus on the health sector being a major employer of women. And this sector urgently needs to address gender and intersectoral inequality and power imbalances. And I would say here it's not only globally, but as well in European region. So women accounts for 67% of global health and social care force, and the financial value of women's input to health system is about 3 trillion annually. However, women in health tend to be clustered into the lower status, lower paid, and often unpaid roles. I'll stop here.
Thank you very much, Elena. Very interesting statistics there on the health workforce. I think is a huge issue that has to be addressed. And we have to look at parity in relation to the health sector, women from a gender perspective. Very happy now to talk to Neerja. Neerja, working with the WHO, as many as 1 in 5 women experience mental health problems in pregnancy, such a huge issue during pregnancy and such an important one, or after birth, with perinatal and postnatal depression being particularly prevalent in maternal in pregnancy. So what can we do to better identify those women who are at risk and support those women struggling with their mental health during this time?
Thanks a lot, Peggy, and thanks so much for highlighting the importance of mental health in the report. I think it's so crucial. We know that mental health itself is one of the most neglected areas of public health. And despite the huge burden, even in high-income countries, it's many people with mental health conditions don't receive the care that they need. This is more so with perinatal mental health and, like you said, maternal depression, which goes under-recognized and under-treated for many reasons, including we heard about, healthcare workers and the skills of healthcare workers. So they need to be trained to identify these conditions. And also, let us not forget that parents and caregivers of children seeking mental health care is very low because of the fear of stigma and poor mental health awareness. So that's something else we need to tackle. There also the reason why this is important, we heard about maternal mortality. We know that women with perinatal depression also have high incidence of acts of self-harm and attempts of suicide, which also would increase maternal mortality during this period. There is also the intergenerational effect. Children born to women with depression are 1.5 times more likely to be underweight and stunted. So we need to think about the impact that maternal depression has on the next generation too. The good news is that I think, and we're all hoping for good news, is that there are actually effective and cost-effective treatments for maternal depression, both antenatal as well as postnatal depression. And these, in fact, can be provided by non-specialists. Now, when I mean non-specialists, I mean non-mental health specialists. So doctors, nurses, midwives, those working in maternal and child health care, those working in antenatal clinics can be trained to identify, to screen women for mental health conditions, as well as to provide treatments. And these treatments, in fact, can be provided in a stepped care manner. So I think what's important is for us to recognize that when we speak about perinatal care for all women should be welcoming, friendly, collaborative, and provided in a non-judgmental manner. This will then give us a strong foundation to build a positive relationship, to then be able to identify and be able to enable disclosure of mental health problems. We can then train healthcare providers who are working in maternal and child health care to screen for depression as well as anxiety, and to provide low-intensity interventions if women are at risk or if women have symptoms of these conditions. For example, psychosocial interventions that include psychoeducation, stress management, strengthening social supports, promotion of functioning and life skills. And also, once there is an identification that a woman has depression or anxiety, there can be more resource-intensive interventions provided. For example, there are brief psychological interventions. WHO has a Thinking Healthy program, which is a cognitive behavior therapy-based intervention that can be provided by counselors in women's homes, in fact. So, people who are visiting women during the antenatal and postnatal period can be trained to deliver this intervention to women with depression. And we also then what we need to ensure is that there is a referral mechanism. So women who need more intensive care can be then referred to a specialist in case there is a need for that. We also have a guide for integration. I think the important thing is that rather than delivering mental health care in a silo, it needs to be integrated into maternal and child health care, into early child development programs. And we have a guide to enable program managers to be able to do this, to take them through the steps of what it means to integrate mental health, how they can do it, how they can plan for it, budget for it, provide the training for it. And then, of course, most importantly, and we've been hearing about this from the other speakers, is to be able to monitor and to be able to provide data on how effective these programs are. Let me stop here and hand back to you, Peggy. Thanks a lot.
Thank you very, very much, Neerja. I think it's a really interesting point, and maybe further discussion is needed on a universal screening program for perinatal mental health and disorders provided multidisciplinary. That's a very interesting point to make. Can I come to you now, Mervi? And Elena mentioned the importance of the healthcare sector and also the real importance of the contribution of midwives. Across the EU, maternal mortality rates are decreasing. Why do you think this is? And is it even across populations? And we also see that midwife-led care is commonplace in the Netherlands particularly. And are there advantages in this system? And does it affect maternal health outcomes? I know that's a lot to answer in once, Mervi, but over to you.
Thanks very much, Becky. And it's really good to come as last in a panel, as such to say, because so many people have repeated exactly what we think as a midwives that are issues across Europe and of course globally also, Elena. And it's so important to have reports like yours, Becky, to surface and actually have the support of the MEPs, because we all need to work together to improve the women's health across Europe. So I agree fully that maternal and perinatal morbidity and mortality has certainly reduced in the European region, and mostly sort of kick-started by the Millennium Goals and continued by the Sustainable Development Goals. And some countries, the reduction has been more marked than the others. So we are concerned what is actually influencing the changes. And some of it has been on the EU level policy recommendation that Isabel mentioned, and also the drive to collect data. So we know we have more data and we have more awareness of actually what is happening across Europe. But the disparity does still exist, and especially on the communities. Now, having worked on a European agenda such a long time and recently attended on the sexual and reproductive policy arena, unfortunately, the newest reports and the data for the last year show that there's quite a lot of slowing down in certain countries where the drop has been the highest, and also that there's even an increase in some countries, and I think maybe those numbers will come more apparent on the next 3 to 4 years. But as a midwife, we sort of understand that the childbirth is an event or experience that has always been deeply embedded in the societal norms and influenced by the social environment where the birth takes place. So Though we think that the care of the women in pregnancy and childbirth has improved by the better clinical management and shared guidelines, especially even provided by recommendations from WHO in antenatal care and intrapartum and postnatal care, there are some changes that are now in retrograde, and I think they were mentioned by Elena. The access to contraception and safe abortion has really hit some countries very hard, and also that the women do not have any choice of actually for the contraception or accessing those services. Also, COVID highlighted, when we did some studies amongst the midwifery community, highlighted the difficulty of getting effective guidelines that were agreed by health professionals that were actually providing the care to the women. So midwives were often not involved in discussing practices like water birth or breastfeeding and etc. That what should be the recommendations during COVID period. So there's still a lack of this interprofessional working, but also even working with the governments and the health departments to provide guidelines that are women-centered and also clinically research evidence-based. And as you said, even more evidence is raising that the vulnerable populations like adolescents, migrant and refugee communities, and women facing gender inequality are hardest hit and have poorer outcomes, even if the country has average good outcome of maternal mortality and perinatal mortality. So we have discussed within countries like even Sweden and Nordic countries that were mentioned earlier in your report that have such a good numbers, even they have differences between the population of the refugee and migrant population compared to their own Swedish-born population. And I'm just picking Sweden as one country. It is not specifically because it's such a high levels. It's just understanding that we need to look at even the high income countries and etc. when we look at why is it and look at the root causes. It could be the financial circumstances that were mentioned, that, but it also often is communication and access. Midwives really truly find communication is a key. The women are not heard, but also they are not able to communicate their needs or where do they need to get the care from. So this is, I'm coming back into that, why midwives are really investing in midwives is so important. And the current crisis of the high levels of migration that includes women and newborn have highlighted the inflexibility in the delivery of care. And in maternity itself, it has really mobilized the midwifery community to ensure that women have better access to maternity care, which has been a big challenge and hasn't really often been supported by the health systems in the country, but by charities, having projects so that the midwives can provide services in the camps and the border camps, etc., where women have ended up either pregnant or already have a newborn. But it has also provided positive experiences in that some countries midwives are not able to practice in the community, and this has opened roads to actually go near the midwife, go near the women where midwifery care should be really delivered in their own environment, and given them more autonomy to design the care delivery and also working with the women together of improving conditions. And as was mentioned before, we are really equally concerned about the raising cesarean section rates, that they have not reduced the maternal mortality. Evidence is clear, and have risen in some countries to the levels which are clearly unacceptable, 50 to 60%, not just over 35. We are talking about reality of 50 to 60%. So we need to be realistic how this is seen to increase the data on morbidity. Not so much mortality maybe, but and when you add to that an overuse of antibiotics that are a norm as a guideline within cesarean section, this is an agenda which EU is addressing with reduction policies on antimicrobial resistance. We are just adding into that pool of people that are using antibiotics as prophylactically and not because it's required. And we also struggle to have a long-term data on the health of children born by cesarean section. So midwives in Europe strongly believe that better access to midwives, their autonomy to deliver care, and working with women's groups can improve these traits and health and well-being of the nation, as Elena mentioned. And that comes back now, what you asked about the midwifery in Netherlands. I mean, midwifery-led care has been, but it is really difficult to actually find it in all health systems. There are pockets of midwifery-led care outside Netherlands, and it's something that we sort of, in the community and with the International Confederation Midwives, we greatly support. That should be a policy and strategy in each health system. And certainly, midwives who are educated to the level of EU directive and are able to practice fully to their scope of practice can deliver safe quality care for all pregnant women and provide midwifery interventions that improve or maintain the health and well-being of the woman. So what does midwifery-led care mean? It just means that there's a better opportunity for continuing care by named person that the woman gets to know. And also often that person in Netherlands is actually accessed in the community. So the women know where to go and where to find a midwife. When in the countries where the midwives only work within the institute, it's a much more complicated way, and they have to usually go through the doctor's referral. And then the money comes into it if there's independent practices of gynecologists and obstetricians who need to earn money to deliver the care. But it does not mean that midwives would work in isolation. Midwives and women basically to be in isolation, but it would be a better use of resources and engagement with the wider professionals team, which is needed during a pregnancy and childbirth. We have now good evidence, even modeling how midwifery-led care and midwifery intervention can improve outcomes and reduce maternal mortality. So, you know, we can't close our eyes or ears for this evidence, but we need to apply it into the way the policies and national health strategies policies are built on.
That's great, Neerja. That's great, Mervi. Thank you very, very much. Thank you. Just before we end, I'd like to give the other experts just a minute to ask them just one more question. Neerja, could I come back to you and ask you, how do you think policy can support women's mental health during pregnancy and after?
Thanks, Peggy. I think what we have is really, in terms of policy, and I keep repeating this, is not providing mental health in mental health policies alone, but incorporating them into all government policies. In fact, we have an excellent opportunity in the EU in June. In fact, a new initiative on mental health was launched called a comprehensive approach to mental health. And I think leveraging on this initiative is important to focus on maternal mental health. We can address mental health across the life course, mental health promotion, prevention for women, social determinants of mental health, which are so important, provide adequate training and upskilling of health and social care workers, and targeted to specific needs of women and mothers. So that's one way we can leverage this. Also, I think what's very important is to think about accountability. So having effective data collection mechanisms, we're talking about standardizing indicators, ensuring that these indicators include mental health indicators. I think that's really important. And this will help us then, of course, sharing best practices across EU countries, which can then improve policies and services throughout. I think this is how I'd like to summarize it. And thank you very much for the opportunity.
Thank you so much, Neerja. And Elena, I mean, you were emphasizing the fact that we need to improve health literacy. And how can we better educate everyday citizens on good maternal health?
Yeah, you're very right, Peggy. It's the public health campaigns are very important. I would just put 3 points that I believe are critical. First of all, there should be a very strong message in all the campaigns that bodily autonomy of women and girls is a fundamental human right. And without this shift in understanding, we risk to have no progress. So, I mean, this is first. Secondly, we have to educate both men and women. it's not enough only to tackle girls and women. Men are critical. I mean, in families, in EU, globally. I mean, this is super important. And as I mentioned before, comprehensive sexuality education has to be a part of this campaign. Young people need to get proper, timely, according to their age, information about their health and about their reproductive health. So I would say those three elements are critical.
Thank you very much, Elena. And lastly, Mervi, very quickly, would you have anything to add to what you've said already?
No, I think very much in conclusion that women should all have opportunity to access respectful, woman-centered care, that it's accessible in their own environment, which most often is community. And this must be a key of the future of primary care that we provide. Midwives have to be part of that team. Thank you.
Thank you very much, Mervi. I'm not sure if there's any questions in the Q&A, but if there are, we're happy to answer them if you by email, if that's okay. And we can provide our email and you can send the questions to us. So I'd like to thank everybody for taking part in the discussion today. It was very, very interesting. And I think maternal health is such a huge issue for women. And we hope to work on that issue and the issues that have been brought up today in the interest group in the European Parliament moving forward over the next couple of months, particularly leading up to the elections. And although we see that morbidity and mortality rates have decreased, we do know that there's huge disparities across the globe, basically. And so therefore, we really need to address these, and we need to work together globally to improve women's health during pregnancy. The importance of data still isn't satisfactory enough. And as we know, the social determinants of health are having a huge impact on women during pregnancy. So I'd like to thank everybody. I think Isabel is gone. In case you think I've missed Isabel, I think Isabel had to drop off because she's another meeting to go to. I'd like to thank everybody for taking part, for Barry Andrews for hosting the meeting and the Rebecca's presentation. And we look forward to working with you over the next months and years with the interest group in the Parliament and globally as well, and with the WHO and UNFPA to improve and support women's health, particularly maternal health care. Thank you very, very much. Thank you.